Excellencies, colleagues, friends, good morning. Thank you for being here. We began today by writing our worries and our hopes. I am carrying both, but this morning I choose to let hope lead. My name is Margaret Odera. I am a community health worker in Mathare North, Nairobi, and I am a person living with HIV. I'm here to share what the last months have looked like for my community and why sustainable professional community health worker financing is not a luxury. It is the backbone of health security. In February, the services began slow. In March 2025, fear became real. In our HIV services, patients began receiving only 1 month antiretroviral instead of the usual 6 months. Viral load testing kits ran out. I myself, I missed my viral load test because the kits simply were not there. In immunizations, there was an acute shortage of vaccines, especially pentavalent, the critical vaccine for newborns and young infants. Mothers traveled long distances, 200 kilometers or more, to search for a dose, and sometimes arrived to find that there was none. There was staffing gaps. In some days, there were no doctors or nurses to dispense medicine. One day, 17 pregnant women living with HIV went home without ARVs for PMTCT, and that is a sentence that no one should ever think or ever speak. Community health workers stepped in. We took blood pressure and weight. We triaged clients. We called the county nurses. We did whatever we could to keep the line from breaking. But emergency improvisation is not a health system. It is a warning. Today, thanks to AHF and CHWs, my clinic has stabilized. Yesterday was my clinic day. That was on Friday. I received medication through February 2nd, nearly 5 months from now. In many facilities, we are back to the 6-month supply. This is a relief, and I am grateful. But these are contracts. They are temporary. The fear still remains. But for how long? Viruses don't need passports or visas. If there is an outbreak in one county or one country, it can become everyone else's crisis. Polio, TB, measles, Ebola, they don't respect borders. If a newborn misses a routine vaccine today, that gap can become tomorrow's emergency. When funding is abruptly cut, the first cracks appear in community, and then they spread. When community health workers are paid, trained, and integrated, we extend reach, we keep people in care, we sustain trust, we help every dollar go further, not just by saving money, but by multiplying impact. Stretching scarce resources and building durable platforms that make health systems resilient. My worry is simple, that we accept emergency chip-ins as a strategy. My hope is also simple, that we commit to professional, salaried community health workers and sustainable financing so that what happened in March should never happen again. Thank you for listening. And with that, I am honored to hand over to our colleagues to share how we turn this hope into policy and budgets as last. Let us give it up to Ash Rogers and Dr. Oguel. Welcome.
Thank you very much, Margaret. It's always a pleasure when those who do the real work stand up here and remind us what that real work is about. Talking about it and doing it are two very different things. A very good morning to everybody. My name is Ahmed Ogwell, and I'm CEO at Village Reach, and a very proud SHIC member.
And hello, I'm Ash Rogers. I'm co-CEO of Lawala Community Alliance, a proud SHIC member, and also a member of the SHIC Advisory Board. And we're so excited to have you all here with us today. For those of you who are new to the Community Health Impact Coalition, SHIC, our mission is to make pro-CHWs the norm worldwide. That is through changing guidelines, policy, and funding. Community health workers, just like Margaret, who we've heard from, they're trusted by their neighbors to extend care to every home. Research shows that they improve health access and health outcomes, and that for every dollar invested in a community health worker, we get a 10-fold return. And yet, community health workers are woefully undersupported. We rely on them in pandemics and crises, and yet many go unpaid. That is why we are committed to professionalizing community health workers. A pro-CHW is one who is paid, trained, supervised, and equipped to deliver health for all.
And we all know that successful interventions are only sustainable when we see clear policy change. SHIC's global progress in advancing pro-CHW policies is reflected in this new dynamic dashboard, which is up here. It highlights where momentum is building and where strategic mobilization is actually needed. Currently, we are tracking the salaried and accredited status of CHWs in each of these countries. The goal, every country on this map turns purple, signaling that CHWs everywhere are set up to deliver quality healthcare at the last mile.
So far, 50 countries have passed pro-CHW policies that accredit, pay, and supply community health workers. And many of those countries are in this room today. 9, thank you, yes. And 9 have been added to this list just in the last year.
A critical enabling factor to achieving policy wins is the rigorous evidence that decision makers depend on. How does that show up? We have published 16 peer-reviewed papers with almost 180,000 views. 2/3 of these papers include CHWs as co-authors, helping raise CHW voices and visibility in the global health space. When people who are delivering care shape the evidence, research is stronger, it's more relevant, and it is more likely to drive change.
The real magic of SHIC is that all of us coming together are able to speak louder than any one of us could alone. And that is why some of the biggest funders and norm setters in the world rely on SHIC and trust us and give us the opportunity to help influence their policies, their strategies, their guidelines. That includes Global Fund, UNICEF, Gavi, the Asian Infrastructure Investment Bank. And SHIC also contributed to the WHO's first guidelines for community health workers. And all of this is meaningful. WHO has 194 member states who look to their guidelines as they're forming their own policies. So when community health workers are written into these policies and guidelines and strategies, that translates into real resources on the ground.
And actually, global recognition of our impact is growing. Since 2024 October, SHIC has received various recognitions. IHME's Rowe Prize, Schwab Foundation's Collective Innovation Award, and the Skoll Award for Social Innovation, meaning Our vision to professionalize CHWs is resonating on the world stage, and it is reaching much wider audiences.
CHIC is translating this momentum, the increased evidence, the new global guidelines into policy change at the national level via CHIC members. For example, in Kenya, CHIC members came together under the leadership of the Ministry of Health to form the CHU for UHC, which is a powerful national coalition that includes Lawala and Village Reach and Living Goods and Medic and 28 other civil society organizations in Kenya. It includes Margaret's organization, which is the national organization organizing community health workers. And together, we were able to work with government and support some landmark health reforms. The Kenyan government has committed to and actually put in national resources to pay community health workers, to equip them, and to support them with an electronic community health information system. And what's exciting is that Kenya's not the only one. CHIC is collaborating with 7 national NGO coalitions and 8 CHW-led coalitions around the world.
And at this juncture, I would like to congratulate the Honorable Minister of Health of Mozambique, because Mozambique is developing new approaches into the health sector, and the community is at the center of that. So congratulations, Honorable Minister. CHIC's recommendations are included in the updated WHO benchmark for strengthening health emergency capacities, a major step in embedding community health worker priorities into global standards. It ensures that community health workers are recognized as essential to preparedness. Ultimately, though, embedding community health workers into emergency preparedness frameworks isn't just a smart policy. It's a strategic imperative for resilient health systems that serve everyone, everywhere, especially the most underreached communities.
It is now my pleasure to introduce the woman of the hour, our fearless leader, the CEO of Community Health Impact Coalition, Madeline Ballard.
I'm not sure about women of the hour. I think the woman of the hour has already spoken, and we're going to hear from another one later in the program. Thank you all for being here this morning. So I come to you today. I was born in the year 1989. I know we don't like to reveal our ages. You can do the math. But I bring that up because 1989 is also the year that the US invaded Panama. It's the year that the Exxon Valdez caused one of the most ecologically damaging oil spills in history. It's the year that thousands of democracy protesters were massacred in Tiananmen Square, and the year that the Berlin Wall fell. It was a chaotic capstone to what many have termed a lost decade, in which soaring inflation rates cause a debt crisis, economic stagnation, and rising inequality. It might sound a little familiar. But in this lost decade, something was found. Because even as ministers of health at that time were grappling with declining aid, with brutal structural adjustment programs, they were making bold plans. Because UNICEF's Jim Grant, during that period, had been rallying researchers and ministers of health and frontline health workers around a single, profound, and important goal: save the lives of children. And that's what they did. Ceasefires were declared. Health programs were introduced. And by the end of the decade, the vaccination rate for children had climbed from 20 to 80%. In the year 1990, at the end of the lost decade, more than 25 million children who otherwise would have died were alive. Today, the ground shakes again. We have a climate that is spiraling out of control. We have more conflict at this moment in history than at any time since the end of World War II. And of course, we have cratering trust in our shared institutions. And once again, we are told that there is no money. And yet history has already told us that progress is not just a question of fortune, but of focus. The animating question behind the child survival revolution in the 1980s wasn't just, what can we afford? It was, what can we not afford to defer, even in moments of calamity and scarcity? And it's animated by those questions that more than 30 community health workers and researchers from more than 5 different continents across Community Health Impact Coalition came together over the last 2 years. What did we do? We systematically identified and analyzed every single study, piece of economic evidence published over the last decade on community health workers. That's 255 studies describing more than 380 community health program scenarios. The results of that work are unambiguous, and I'm going to take you through them now. If you want to save children, and you want to do them in a cost-effective way, and in a way that absolutely cannot be deferred despite the challenges that we now face, community health workers are the answer. They were found to be effective in more than 80% of cases when treating mental health, non-communicable diseases, and more than 90% of cases when treating mothers, children, HIV, TB, malaria, the list goes on. In fact, there's so many things that they do, we needed to publish it in 5 separate papers. And they're linked on your QR code. You can access those as they're currently coming out in the academic literature. And I think it's important to note the price point of all this, right? This is just $10 per patient per year. Or, put another way, $6 per person per year for a comprehensive package of primary health care, everything from vitamin A supplementation to treating malaria cases. That is a rounding error for most high-income health systems, and it's about 5% of what most low-income countries spend per capita on health every single year. The bang for the buck is there. Because when we invest in community health workers properly, supporting them, they stretch dollars, they reach more people, and they do so with better value for money. Community health workers, it's important to note, don't just match facility-based or other types of models. They consistently exceed those targets. They consistently exceed those outcomes. And it's worth noting that they're not just doing this in ideal conditions, right? Community health workers are reaching the people that other parts of the health system or other models are not reaching. In one of the studies we found from Tanzania and Kenya, community health workers were actually able to reach mothers and children in some of the most remote areas of both of those countries. And yet if you looked at the health outcomes of those mothers and children, they were better than the health outcomes of those mothers and children being treated at the nearest facility. And of course, it was done for less money. And why is that? That's because community health workers don't just deliver care. They deliver proximity. They deliver cultural fluency. They deliver staying power, something an algorithm might find difficult to replicate. And I think another really important finding of this giant, most comprehensive cost-effectiveness analysis of community health workers to date is that the economic evidence reconfirms what the impact evidence has long told us and what Community Health Impact Coalition has long advocated. And that is that not all community health programs are created equal. One of the key findings was that integration is a value multiplier. What does that mean? That means if a community health worker is connected to a nearby health facility, they are digitally enabled, they have salaries, they are accredited, and they are providing care for multiple types of ailments at once. So again, everything from vitamin A, HIV, malaria, they are far more likely, that program is far more likely to be cost effective than a single disease vertical program. Effective altruists, take notes. We want to follow the evidence here, right? And I think it's important to note that when we're investing in community health workers professionally, as professionals, we're not just saving money, right? We're saving lives, we're stretching resources, and we're preparing systems such that they don't crumble in the face of the next crisis, as Margaret shared. In 1989, a unified coalition of actors proved that even a small band of folks who are committed to an idea can bend the arc of history. It's because leaders in the 1980s invested with clarity, with confidence in health, that 25 million people, my exact age, are alive today. Our crises demand that same clarity, that same long effort in a single direction. Because ultimately, history is not written by people who simply capitulate to the conditions of their age. It is written by the people who find a way. And now is our time. And I'm so pleased to welcome onto the stage the people who in this moment are finding a way, to ask them how they did it. So let's welcome our esteemed panel to the stage. First, I'd love if everybody could give it up for the Honorable Mr. Oseni Hilario Isse, the Minister of Health of Mozambique. If we could also welcome to the stage Dr. Uma Uluga, the Principal Secretary of Kenya. And Dr. Gregory Ganda, the Kisumu County Executive Committee leader. Jennifer Schechter, the co-founder and CEO and proud SHIC member from Integrate Health, to the stage. And Carmen Villegas Vargas, a community health worker from Peru, the president of the Lima Community Health Promoters Network. So if you have not yet set up your interpretation, we have English, Français, Espanol, and Portuguese. And you can see the instructions on the screen now. Everything's impossible, and yet the people on the stage are doing it. Let's figure out how it's happening so that we can join them, right? So I'd love to start. We've already heard a little bit from our colleagues to start the event about the reforms currently underway in Kenya. So I'd love to start with Dr. Uluga, if we could, the Principal Secretary. So Kenya has obviously made tremendous strides in supporting community health workers to provide great care to Kenyans living everywhere. How's that? It's a national win that has inspired, as you can see, many in the room and around the world. And I'd love to hear how those achievements were enacted. What role did Parliament, CHW associations, civil society, presidential leadership play in making this national milestone possible?
Thank you, Madeleine, and good morning to everyone. So yeah, we are here to confirm that this is the right direction to go, and community health workers, now in Kenya called community health promoters, have been an integral part of the healthcare system. Two things that have made the difference One is political leadership and commitment. And I think the president took this as his personal agenda. Community health workers and community health promoters have been in Kenya for quite a long time. The journey towards a sustainable, systemic, structured way of engaging them and a structured way of connecting them to the healthcare system that was sort of, loosely engaging with community health workers is what needed the president at his level, because the evidence has always been there, to make a commitment. And what did we do? We established Primary Health Act, and Parliament passed it. So the Primary Healthcare Act has in it a very structured role for the community health promoters and how they engage not just with the other professionals within the health system, but how they engage with the communities, how they link with the facilities. And Parliament was a game changer there. And so far, we have had more than 38 million screenings for diabetes alone. More than 38 million screenings for diabetes alone. And if you were to extrapolate that number to all the other diseases, the screenings that have been reached for malnutrition on children, the work that has happened when it comes to maternal health, the pregnancies that they have reached. If you were to look at hypertension, we are almost at 47 million. We have conducted almost 990,000 that have been referred because of high-risk pregnancies over the last 3 years. So there is quite a lot of evidence for that. And we have found this to be the foundation of the resilience healthcare systems. And for us, it is something that we are not going back on. That is why we have now salaried 107,000 community health promoters. And I'll leave it there for now. Thank you.
Thank you. I know that when you walked in the room, you saw Margaret and you immediately knew who she was. Talk more about that.
I know Margaret very well. I am extremely privileged. The organization, the Association of Community Health, they still call themselves volunteers. I think, Margaret, that name should change. Association of Community Health Volunteers of Kenya. I was very privileged to be the patron of that organization. And I started when I was still a director of health in the Nairobi city, in charge of health of Nairobi City County. Thank you.
Thank you, Dr. Luga. Appreciate it. I'd like to hear from your colleague, the Honorable Minister of Health of Mozambique. Minister Isse, Mozambique has likewise shown strong leadership when it comes to community health and is in the series of passing a whole series of government reforms that sound very similar to what Dr. Honorable Luga has just described. Can you share more about these provisions and the future plans by the government of Mozambique to formally regulate, compensate community health workers and ensure that they're set up to provide health for all?
Good morning, everyone. Good morning, everyone. Good morning. Good. I apologize. I will speak my native language, Portuguese. Yes. Please. Yeah. Em primeiro lugar, quero agradecer com muita humildade e respeito o convite para participar neste importante evento. Segundo, dizer que o subsistema comunitário é uma grande prioridade em Moçambique. Moçambique conta, neste momento, com cerca de 8.000 agentes polivalentes de saúde, que cobrem cerca de 30% a 40% do acesso aos cuidados de saúde. para dizer que, se queremos ter uma cobertura universal de saúde em África, uma das grandes prioridades é o envolvimento comunitário, é o subsistema comunitário. Aí que temos, no nosso país, um alto compromisso político do Presidente da República. O Presidente da República de Moçambique, Daniel Francisco Chapo, escolheu o subsistema comunitário como um pilar da sua governação, porque acreditamos que o bem-estar da saúde dos moçambicanos está no subsistema comunitário. Dizer que, só a título de exemplo, melhoramos muito na componente do planeamento familiar. Cerca de 20% das primeiras mulheres que vêm para o planeamento familiar é com o agente comunitário de saúde. Reduzimos a malária, a tuberculose, o HIV, a desnutrição crónica, que é um grande problema de saúde no nosso país. Estes agentes comunitários têm dado uma grande contribuição na prevenção e na promoção de saúde. Tendo isto como uma necessidade urgente para a África, no âmbito dos cuidados de saúde primários de saúde, o país está a desenvolver várias iniciativas. A primeira iniciativa importante é trazer estes agentes comunitários como trabalhadores da saúde. Para isso, estamos a mobilizar recursos domésticos para o pagamento e enquadramento destes agentes comunitários no aparelho do Estado moçambicano, para serem funcionários do governo, a serem remunerados com recursos domésticos para fortalecer cada vez mais o sistema de saúde. Neste momento, o pagamento dos agentes comunitários de saúde é feito pelos parceiros de cooperação. Quero aproveitar esta oportunidade para agradecer o apoio de todos os parceiros que têm contribuído para o fortalecimento deste sistema de saúde em Moçambique. É importante também dizer que o nosso país está a trabalhar naquilo que é a formação dos agentes polivalentes de saúde. E esta formação é dada ao nível de escolas preparadas, nos institutos de formação de saúde, onde é que estamos a ensinar como estes agentes têm que tratar os doentes na comunidade. Por isso, estamos aqui para dizer que estamos a regulamentar o subsistema comunitário de saúde, por um lado, mas por outro lado também esperamos ainda mais contribuições de parceiros, nomeadamente aquilo que é o alinhamento da ajuda dos parceiros com as prioridades do governo. A questão da agenda de Lusaka, um plano, um orçamento e um sistema de reporte. Isto é muito importante para a África, para podermos fortalecer cada vez mais o sistema de saúde, para dizer que há ganhos importantes com os agentes polivalentes de saúde do nosso país. Por isso, pela vossa atenção, muito obrigado. E vamos construir Moçambique com a ajuda deste contingente, que é muito forte nas nossas comunidades, e o governo de Moçambique pegou isto como uma bandeira, como um pilar e como uma prioridade para Moçambique. Muito obrigado pela atenção dispensada.
Thank you so much. Yeah, just another, huge round of applause for all the immense progress and government reforms undertaking in Mozambique currently. So, Dr. Ganda, the Kisumu County Executive Committee, we've heard from both Honourable Isse and Honourable Iluga about two things. One, that community health is the pillar of the health system, the basis, and two, that there's a whole bunch of national architecture, political infrastructure that's required to support these workers and ensure that they're ready to provide healthcare for all. Evidently, it's at the county level. Kisumu County is a county in Kenya, where the national policy reaches that community reality. And I know in Kisumu County, you have been exploring, on the theme of today's talk, innovative financing mechanisms to mobilize both domestic and donor resources for community health. Can you share how you're not only increasing financing, but ensuring the sustainability of those community investments? So as Dr. Lugo says, Kenya is never going back.
Thank you. Thank you very much for the opportunity, and thank you for bringing Kisumu to this platform so that we can share our experiences. First of all, I think you've given the background. Kenya has a devolved system of governance, and we have 47 county governments, which are local governments, and I lead one of those county government departments of health, and that county is called Kisumu. That's where we come from. So as my colleague, Dr. Uma, had said earlier, political goodwill is a very strong thing, and for us in Kisumu, our governor, Professor Peter Anyang' Nyong'o, had this in his manifesto. So in 2017, when he came into government, he had put in his manifesto that he is going to strengthen community health, primary health, by strengthening community health. So for us, it was not an option. It was something that the County Department of Health had to deliver. And 2 years after his election, we had our first act in terms of policy. That was the Kisumu County Health Act. And inside that act, we had a paragraph which talked about community health. So now delivering on that policy which had community health became our problem. And what we did, he actually went to visit one of the counties and found something interesting and pulled a new partner, Living Goods, to come to Kisumu. And so we did some cost-sharing agreement on how we could be able to deliver community health. And they gave us a lot of technical support in terms of digitization, in terms of supervision of community health workers, and they helped us using the platform that was formed nationally to form the first policy, county policy. Now, these are very important because these acts are what make it legal for government to be able to spend money. But then it makes it sustainable because any other government which comes in, there's a policy in place that allows it. So that by itself was able to allow us to sustain. And we started from 0 shillings government. It used to be purely funded by partners. But then after a while, we were investing $3.2 million US, but up to now, we're investing around $3.9 US every year for community health, showing that we are actually improving the amount of money we are putting in. But then something very nice happened in 2022. The president who came in also had community health as a pillar. And so that was very nice for us because in 2023, when we signed a cooperation agreement between the national government and county government on a cost-sharing model for community health workers, it brought in more money into the system. Our community health workers now got double the amount of stipend. They were getting $2,500. And then the national government also took over the issue of kitting them and buying commodities because it was a very expensive thing for us to be able to do as counties. And so that improved the amount of money which was available for the system. Now, coming into innovations, what are we doing? Apart from the policies that I've talked about that make sure that amount of money is always available, there was a second policy which was very important, something called the Facility Improvement Fund. You know, our communities are connected to the health facilities, and having funds in these health facilities, in the primary healthcare facilities, ensures that actually this money can actually be reinvested into the community health systems because the community health workers are linked into that facility. That's the first thing. The second thing we've said is that the infrastructure is formed. You have a digitized person who walks house to house and visits every community member and has a digital platform. It's like a vehicle. When you buy a vehicle, if somebody comes, he must use the vehicle for you to get the returns. When he buys another vehicle, then you don't get returns on this. So we've insisted that all our partners use this system, and actually it is delivering. One of the nice programs I like talking about is the HPV screening. We use our community health workers for door-to-door self-collected HPV screening, and the partner, the donor, is able to see, because you know this community health worker is taking care of 100 people, and so how many people are of that age? They are 70, and it's doing very well. We are doing up to 80% coverage of mothers, and the partners are very happy because it's visible. The second thing we are looking about, how do we leverage this on telemedicine? They are able to walk to the community members and have a chat with the doctor. So there's some community members spend a lot of money to come to the hospitals. They're old, they don't want to come to the hospital just to get a refill. That platform is available for them. We're also using it to deliver medicine. If you're coming for a refill, instead of coming every 3 months, you might not have enough money to buy the whole 3 months. So you get a 1-month refill, and the second month you have to travel all the way to go and get. The community health worker is there for you. So this platform is actually increasing the amount of financing available into the system from all our programs and all our partners. And so we have been able to show that actually if we have good financing models and we can innovate around the financing, if we have political support, and if we work well with our partners, we are able to deliver the community health systems to our people and improve the primary healthcare systems. Thank you very much.
Thank you, Dr. Ganda. Yeah, that triple recipe of politics, financing, and a supported workforce is very powerful. It actually reminds me, one of the other studies that's profiled in this cost effectiveness analysis speaks to some of the savings that you just mentioned are happening in Kenya with HPV. If you look across the continent at Liberia, there was a study that demonstrated that those community health workers who are also integrated, also digitized, like the community health workers in Kenya, were able to slash the cost of treating non-communicable diseases, neglected tropical diseases, by up to 10 times compared to vertical programs. So that integration that you're driving is really a major cost saver. Jenny, you mentioned, or we've heard Honorable Ise, Honorable Luga, now Dr. Ganda mention partnership as a really critical driver over and over again of getting this done at a country level, both in a way that were such that it happens in the first place, and also such that it sustains. I know we have a number of people here today from civil society, and I know they're always curious, and the topic always comes up, of how can organizations like Integrate Health, which works in Togo and Cote d'Ivoire and across West Africa, how can civil society really be a great partner in achieving these health gains, not just in a county where you're delivering direct service, which is critical, but also making that go national?
Thanks, Madeline. So it's kind of a big responsibility to represent the NGO voice when I'm in the room that has the most effective group of NGOs that you will find during this whole entire UNGA week. So I take that responsibility seriously. But at Integrate Health, we think about our role working with government as what we call a learning lab. So we gave it this name to really try to underscore what this means, but I'll break it down for you, and it's really 3 very simple things. So the first is exactly what you just said and what we've heard from our ministry colleagues, partnership. So what I mean by partnership is real relationships. So we do this at Integrate Health by our colleagues form relationships with their counterparts in the ministry at all levels, at the district level, at the regional level, at the national level. We as NGOs, first we have to listen, we have to bring humility, and then we can create a relationship that's anchored in trust. And what this means is that when our partners need us, when the ministry needs us, they pick up the phone and call us. So that's the first piece, real relationships, real partnership. Second piece is risk. NGOs are uniquely positioned to take risks. We have the ability to leverage philanthropic funding to try things that our government partners and our local community partners cannot. And that is a unique privilege. So at Integrate Health, we've used that to test a fully integrated model to strengthen the primary health care system that leveraged professional community health workers integrated with improved facility-based care. And when we did that, we observed a 30% reduction in the under 5 mortality rate at a cost of $10 per capita. Again, underscoring the evidence that Madeline, you shared, this is cost effective and it works. So that brings me to the third piece, which is learning. This is where we bring together these real, genuine partnerships and the ability to take risk in order to generate evidence, in order to learn. But the important piece here is that we're not just learning about the things that we care about or the things that maybe our funders are asking us about. We have to learn about what our government partners are asking about. What are the questions that they have? What are the data points and the information that they need to navigate these hard decisions to understand how to make trade-offs in resource allocation? So I want to share an example of how we did this. I'm going to bring us, we've now gone from Southern Africa to East Africa. I'm going to bring us to Guinea in West Africa. And so now we can't say, oh, this only works in this part of the continent. And And we've done this work both in Togo and in Guinea. And we gave this approach a real pithy title so everybody can remember it. We call it Chunk It, Cost It, Test It. And we've written about the work we've done in Togo to help scale maternal health reform in Stanford Social Innovation Review. So if anyone's curious, I encourage you to read that piece. But today I want to talk about the work we're doing now, live in real time, with the government of Guinea to decentralize financing for community health worker salaries. And so Guinea has, on paper, a very strong professional community health worker policy that both includes payment for CHWs and permits that payment to be administered by local communes. So this is really important because it empowers decentralized government to take ownership of this very important element of the community health worker program. But the government was having a hard time having these payments actually happen. So the policies there, the environment has been created. As Dr. Aluga said, we have the political will. And so the government called us and said, can you help us make this happen? And with generous support from the Global Fund's Project Birch, we started working with 10 communes, so 10 decentralized governance units in Guinea, to look at this approach. So chunk it first, pull out the community health worker salary piece, cost it, figure out how much they cost and exactly what needs to be written into those local government budgets. And then test it. We started working together to test different approaches, create dialogue, really understand what the challenges were. And through this approach, I'm thrilled to share that 7 of the 10 communes that we've been working with are now supporting community health worker salaries from their local budgets. Thank you. So, I think to me what we're all trying to share, if you haven't picked up on it yet, is that this is feasible. There are innovative pathways to financing professional community health worker systems at the local level, the national level, and globally. And we can do this work by continuing to push, as Madeline said, and continuing to follow the leadership of our community health workers like Margaret and Carmen. So thank you so much.
Thank you, Jenny. Dr. Ganda, relationship, risk, and learning. Does that sound like it characterizes the partnerships you have in Kisumu County with another Chic member, Living Goods?
Yeah, it does.
So I think, as Jenny said, the reason why we gather so many people and so many ministers from different countries, as we said, Jenny said, we've gone from Southern Africa to Eastern Africa to Western Africa. We're about to cross the ocean and head to Peru, is that, of course, every country is different. And yet at the same time, the ingredients are very much similar. And so we need both to be connecting transnationally, creating best practices, equipping advocates, creating the financing mechanisms globally that make this possible, and, of course, organizing locally, as Dr. Ahmed and Ash Rogers shared at the beginning of our talk, so that we can bring this, as Jenny said, to life in every single country. To talk more about that, I want to go to Carmen, again, a community health worker from Peru, the leader or the president of the Lima Community Health Promoters Network, and also a Chic member. Carmen, we'd love to have you close the panel by sharing some of the tangible lessons that you've learned kind of co-developing pro-CHW policies in Peru. Why was it so important to have community health workers at the table and collapse that distance between those who are making decisions and setting the policy and those who are delivering care?
Primeramente, buenos días con cada uno de ustedes. Buenos días. Quiero agradecer a la Coalición Impacto de la Salud CHIC y a todos los organizadores que hicieron posible este evento por visibilizar el trabajo que hacemos las agentes comunitarias de salud, ¿no? Tengo 28 años como agente comunitaria. Sé la realidad que vivimos. Bueno, desde mi punto de vista como agente comunitario de salud, no basta con que nos consulten. Es fundamental que participemos directamente en la elaboración de las políticas públicas que beneficiarían nuestro trabajo. Y esto no es solo una opinión, es algo que hemos comprobado con hechos. Este año hemos logrado algo histórico. Impulsamos 3 proyectos de ley que favorecerían a más de 30,000 agentes comunitarios a nivel nacional. Por primera vez, nuestra voz estuvo presente desde el inicio, a diferencia de la ley actual, que no tuvimos ninguna participación. Esto demuestra la importancia de participar plenamente en continuos procesos. Nuestra participación activa nos permite incluir elementos que nos beneficien, como la remuneración digna, el enfoque intercultural y el derecho a sepelio. Este último se incorporó porque vimos tantas compañeras fallecer en sus labores que realizan a lo largo de toda su trayectoria. Estamos creando una red nacional de agentes comunitarios a lo largo y ancho de todo nuestro territorio. Siempre las decisiones se toman desde Lima, sin considerar las realidades de mis compañeras de todo el país. Nuestras compañeras se encuentran en zonas rurales, como la costa, sierra y selva. Se enfrentan a muchos desafíos que nosotras en las ciudades no enfrentamos. Por eso debemos priorizar sus necesidades desde nuestras incidencias. También hemos aprendido que la incidencia no solo se hace desde lo técnico, sino desde lo vivencial. Colaboramos de la mano con la población, acompañando no solo sus problemas de salud, sino también situaciones de violencia, discriminación y vulneración de sus derechos. Ningún informe técnico puede reemplazar esas experiencias. Esas vivencias se transforman en políticas cuando las estrategias nacionales e internacionales reflejan nuestra realidad. Cuando lo hacemos, las acciones dejan de ser vagas y se vuelven efectivas, porque las soluciones vienen desde el territorio. En resumen, cuando los agentes comunitarios participamos directamente en las políticas públicas, el impacto es profundo y duradero. Se reconoce nuestro trabajo y se construyen soluciones reales. Nadie conoce mejor a la comunidad que nosotros que vivimos trabajando y soñando para mejorar todos los días el trabajo que nosotras venimos realizando. Es muy difícil trabajar y que nuestro Estado nos dé la espalda, porque trabajamos así. Pero sin embargo tenemos ese compromiso, esa vocación de servicio para nuestra comunidad. Pero no es solo para nuestra comunidad, sino también nosotras vemos las realidades de este sistema que se encuentra fragmentado. Son muchas las dificultades también. No es solamente luchar por nuestros derechos, sino también por los derechos del paciente, del usuario. Hay un sistema totalmente fragmentado que nosotras tratamos de poner ese granito de arena como voluntarias, pero creo que ese voluntario debe de acabar. Muchas gracias.
I think often when times get tough, we get trapped on this spectrum somewhere between paralytic skepticism, nothing can get done, nothing is good enough, everything's going wrong, or unreflective activism. We just got to get out there. And I think what you've heard today on this stage is effective pragmatism. that we do have the power, we can get things done if we find the right people. And that's why we have these events, right? Because often when we're discouraged, when we're reading the news, when we're having our daily existential crisis, there's this sense that we're alone. But I think hopefully what you take away from this morning is that you're not alone. In fact, there are allies, pro-CHW champions across the globe in every part of every continent, and they're getting up every day and doing the work and making profound progress. And so I'd love to maybe just ask each of the panelists one final, very short question, and we can pass a microphone down maybe 1 minute. And that is, what is giving you encouragement from today that you want to share with those back home or those in the room? What's going to keep you going? What's the energy that's going to drive you? And I'll start, so I give you a moment to think. But I think what I'm proudest of about this movement is that it's both technically right and morally sound, right? We're crunching the numbers, we're publishing them in the Lancet, and we know that those numbers are not the only form of knowledge. That Margaret and Carmen must be there to ask the right questions, interpret those numbers and contextualize them, and ensure that they're applied in ways that match the context. We also need to be coming together across contexts to notice the patterns, that we don't have to solve these questions on our own, that actually, it turns out, from Mozambique to Kenya to Guinea to Peru, many of the same ingredients are there. So we can run the same playbook over and over and over again across the world and make sure, as Dr. Ahmed said, that that map turns purple. So I'm very encouraged by that. Honourable Minister.
Mais uma vez, muito obrigado. Queria terminar dizendo o seguinte: dos grandes desafios que existe nesta componente do subsistema comunitário é a sua sustentabilidade. E a sustentabilidade depende de 5 princípios. Primeiro, compromisso político, que é fundamental o compromisso político. Segundo, a mobilização de financiamento doméstico para cobrir o pagamento de salários para os agentes polivalentes de saúde do nosso país. Terceiro, é preciso regulamentar. Tem que haver um pacote legislativo para que isto seja um assunto do Estado, do governo, e não sendo o assunto dos parceiros. Tem que haver um ownership deste assunto. Quarto, suporte, integração e, acima de tudo, a participação ativa dos agentes polivalentes de saúde nas políticas, na definição de políticas. É extremamente importante. Não deixar ninguém para trás. É isto que nós queremos. Se queremos uma cobertura universal de saúde forte e resiliente, a estrutura comunitária é um imperativo em África. Muito obrigado.
Thank you so much. What I take from this room is that we still have to work together to make greater progress, even though there is evidence that what we've done has achieved results. I think there is much more to be done. And I take the energy that we have to continuously work together to get to where the world should, and to sort of get to the same level. Every country is different. Some started earlier, some have not started. The challenges are different, the ingredients are the same. And I just want to finish by putting maybe on sound what we mean by political commitment. And this was just a week ago, or slightly, I think more than a week ago, when our president was speaking, and I happened to have been in the audience. And I'll just put it, it's only 50 seconds so that we can hear.
The heroes of universal health, the men and women who have made it possible for us to register citizens in SHA, the people who have participated by going to every home and every village in the morning, in the evening, are the CHPs. And I know, tunaelewana jameni, and I know that sometimes there are challenges, but there are counties like Mombasa who are paying CHPs, but there are other counties who are not paying CHPs. What a shame, you know? And I have instructed the Ministry of Health to make sure that as we pay all the other workers, the CHPs must have their money. When the
Thank you very much. I think he said it all. But for me, I think what I learned is that we are not alone in this journey. What we are trying to do is not foreign. It is not ectopic. We are actually working on this journey with many friends, many partners who actually see this world as a better place for all of us in this world. Thank you very much.
Thank you, Dr. Ganda. It's on. So I think I would just add, I talked about how NGOs can take on risk, but I think we all know that those who bear the greatest risk in this work are the community health workers. And maybe I can ask Carmen and Margaret to bring back to your colleagues, and I will take these back to our colleagues in Togo and Guinea, of course, the reassurance that you are not alone. We are working in solidarity with you. We are standing behind you as NGOs, as government partners, as funders, as multilateral organizations, because this work is so important. And we acknowledge that you bear that risk and you do the hard work, and it's a privilege to stand behind you.
Discúlpenme, he escuchado a todos ustedes y la realidad es la misma y los problemas también. Pero lo que me da pena es que nosotros tenemos ese compromiso con la comunidad de muchos años, pero el Estado nos da la espalda. Pero es la fuerza que yo tengo, que animo a mis compañeras todos los días, que sepan sus derechos. Tenemos una ley que no nos favorece, tenemos normativas. De repente sí, alguien tuvo que tomar la posta. Asumo con responsabilidad porque represento a mis compañeras no solamente de Lima, sino de todo el Perú. Creo que estamos por buen camino, pero yo estoy muy agradecida de estar aquí porque creo que, como dijiste tú, no estamos solas. Están ustedes también para ayudarnos, para ayudar a mis compañeras agentes comunitarias. Somos más de 6 millones y creemos que somos el pilar fundamental del sistema de salud. Tenemos un sueño y yo sé que ese sueño se va a cumplir, pero todos, con la ayuda de todos ustedes, creo que así va a ser. Va a ser un sistema de salud con mejora, con calidad. Pero quisiera escuchar desde nuestros gobernantes, desde nuestros propios ministros de salud que digan: gracias, ustedes son mis agentes comunitarias, con ustedes estamos saliendo adelante y el sistema mejora cada día. Y creo que sí se va a hacer realidad, porque veo aquí que hay representantes, hay ministros de salud, y yo los felicito por el trabajo. Y les doy gracias porque apoyan a mis compañeras. Y como dijeron, ¿no? Nosotros llegamos a donde el personal no llega. Y queremos que esto sea sostenible con el tiempo, que permanezca, porque nosotras, detrás de nosotras, hubo compañeras. Gracias a ellas nosotros estamos aquí y nosotros tenemos que forjar esa línea para que las demás, para las compañeras que vienen, tengan algo en qué sostenerse, tener un ingreso económico, que no digan no hay dinero, me voy y busco otra opción. Entonces, muchas gracias, gracias por su apoyo, gracias a cada uno de ustedes y nada, que vivan las agentes comunitarias de todo el mundo.
Thank you, Carmen. Much has been accomplished, but there's much left to do. May all of us stay in the fight long enough to win. A round of applause for our panelists, please. I'd like Carmen to stay on the stage and be joined by Margaret O'Dara to close us out this morning. Thank you.
Este es un llamado al cambio. Basta ya de realizar un trabajo voluntario. Las agentes comunitarios de salud tenemos que organizarnos por las que no están, por las que estamos y por las que vendrán. Buscamos la reivindicación, valoración, remuneración justa e inclusión al sistema de salud. Reconocer nuestra labor no es un gasto, es una inversión. Hacerlo es cerrar brechas entre el derecho y el acceso real a la salud. Porque nosotras somos uno de los pilares fundamentales del sistema de salud, pero invisibles. Conquistando nuestros derechos, mejoramos el sistema de salud y hacemos nuestras comunidades más saludables. Solo organizadas lograremos que estos cambios en pro de las agentes comunitarias tengan sostenibilidad. Un movimiento incluye a los agentes comunitarios, políticos, donantes y equipos técnicos. Todos jugamos un papel importante. ¿Quién asume su responsabilidad? Yo los invito a levantar la mano. ¿Quiénes asumimos esta responsabilidad? Gracias, muchas gracias. Unidos podemos transformar las posibilidades en políticas y las políticas en progreso. Recorramos este camino todos juntos, mano a mano, comunidad, por todas las agentes comunitarias de mi país que represento, Perú, pero también muy importante, todas las agentes comunitarias de todo el mundo. Muchas gracias.
Thanks, Carmen. Don't go. Thank you so much for what you are doing in Peru. Thank you. And we are holding the same in Kenya. The association we formed was able to write a memorandum in 2023 that was positively received by the government. We stand here today with gratitude for the progress we have made, but also with urgency. Together, we have built a chain that we must work together to ensure that the chain is not broken. What is the long-term plan? What is the long-term plan for the 17 mothers who were sent home without ARVs, risking transmission of HIV to their babies? What is the long term for mothers who traveled 200 kilometers for a vaccine only to be turned away? What is the long term for the days when there are no doctors or nurses to dispense medicine, leaving CHW to improvise in crisis? What is the long term for me, a person living with HIV, and for millions like me? What is the long term to ensure that our treatment is never interrupted again? Hope is what carries us forward, but hope alone is not enough. We need concrete, long-term commitment, professionalize and pay community health workers, secure sustainable financing, and ensure that community health workers themselves are at the table to shape policy. Until we have this long-term plan in place, we will always be asking, what of tomorrow? Today, in this room, let us answer this question with action. Come and join Carmen and me on the stage and be part of the chain. Yeah, just come and join us and be part of the chain. Unbroken, united, and strengthened by our shaped hope of commitment, together we will show the world that when the chain holds, health is possible. Thank you so much. You can come and join us kindly. And we take a group photo. Everybody just come in front, and then we can take a group photo together. Thank you. Thank you.
Thank you so much.
Thank you so much.